In this episode of the Nurse Practitioner Videocast, Lorraine Bock and Adele Caruso discuss NP practice in Pennsylvania. Thanks so much for your time today.
Thanks for having us.
Yes, I'm happy to be here.
First, can you please tell us what it's like to be an NP practicing in Pennsylvania?
Well, so I'll go first, I guess. So I would say that it's quite exciting to be a nurse practitioner in Pennsylvania. Both Lorraine and I, we embarked on our professional practice in the early 90s. So, in those days, when we joined our respective practices, we were, one of the pioneers in Pennsylvania, often the first nurse practitioner in a professional group. So I would say that, working in Pennsylvania, it afforded us, many opportunities for professional practice. And certainly we have the clinical expertise to provide high quality care in Pennsylvania. So as far as, something that perhaps is a need that we need to address in regard to our professional practice, I would say that we have one barrier right now, and that's a restrictive business arrangement with our physician colleagues. And that barrier itself is shown to limit patient access in healthcare.
And I think, for me, what it's like to be a nurse practitioner practicing in Pennsylvania is just to see the growth and the change. When I became a nurse practitioner in 1994 in central Pennsylvania, I was the only nurse practitioner in our town who wasn't married to a physician. There were two other nurse practitioners in town, but they were both physicians' wives and they worked in their husband's office. So they were not really looked at by the medical community as being anything other than the doctor's wives. So when I got hired into the family practice that I got hired into, it certainly was a shock to our very conservative central Pennsylvania community. And I'll never forget, in November of 1994, I graduated in August. I started with the practice, and my two physicians were incredibly supportive. They were like, you do what we do. They paid me the same as them. I was on an earn, make what you earn kind of contract, which was not very common back in those days for nurse practitioners. And in November, they came back from the medical staff meeting. And if you remember the medical staff back in 1994, there were no hospitalists. There were no intensivists. Every family practice or internal medicine provider, they admitted their own patients and the physicians took care of them, whether they were in the ICU or whatever. The only thing they really had in the hospital, of course, was the anesthesiologists and the ER doctors back then. Everybody else admitted their own patients. And I'll never forget that Dr. Huff and Dr. Willard came back from the meeting, and Dr. Huff pulled me aside and he said, I just wanted to let you know what's going on. And I'm like, what do you mean what's going on? Like, this sounds bad. And he said, well, one of the physicians stood up at the medical staff meeting and they made a motion and it's about you. And I'm like, wow, I feel privileged that I got a motion made about me. And the motion was that any physician who hired a nurse practitioner who wasn't his wife, they put that little caveat in there to to save the two docs who were married to nurse practitioners. Any physician who hired a nurse practitioner who wasn't his wife would be removed from the medical staff of the local hospital. Now, I immediately was like in tears. I was sure I was getting fired. I thought I was losing my job. And of course, Dr. Huff looked at me and he says, what is wrong with you? Why are you so upset? And I said, well, I'm getting fired, right? And he goes, you're not getting fired. He said, we're making a movement here. We're going to change this. He said, if they want to kick us off the medical staff, we'll take our patients 20 minutes down the road to the next hospital. We have the largest practice in town. So, back then, radiologists wouldn't speak to me. The lab wouldn't take my orders. And nowadays, you don't have any of that. So for me, practicing in Pennsylvania is just seeing this change where patients know who we are. I'll never forget when a patient asked me one time, well, you're a nurse practitioner. What are you practicing to be? And I was like, well, I'm not practicing to be anything, but they had no idea who we were or what we did. And pretty much nowadays, you can't find someone who doesn't know who a nurse practitioner is or what a nurse practitioner does, except maybe in the legislature. We spend a lot of time educating them about what we actually do and who we actually are. And I think, the next step in our metamorphosis or in our growth is to be able to remove those barriers that keep us from being able to practice to the highest level of our certification and our education and training. And the biggest one in Pennsylvania, as Adele said, is the removal of the need for supervision or collaboration with a physician, which is our biggest issue right now. Because if you have a problem, your collaborating physician leaves, they retire, they go to another facility, or God forbid they pass away, you can't practice until you get another one. And that leaves sometimes thousands and thousands of patients. I know Adele has thousands of patients in her practice at the University of Pennsylvania. I have hundreds of patients in my practice in Carlisle. And should one of our collaborating physicians, decide to retire or leave the practice or what have you, we are both unable to practice until we get another collaborating physician and that agreement filed with the state. And that really does affect access to care for patients.
What has your professional NP journey looked like thus far, and what would you like to achieve by the end of your career?
Oh, that's a good one. So I would say that, similar to many of my colleagues, my professional journey began, as an adult primary care nurse practitioner, which is my population focus. And my first position was in 1995. Again, relatively new role for both patients and my physician colleagues in that particular practice in Delaware County. It was my home county. And there it was a large primary care practice. So I was the first NP. I was a huge success. Similar to Lorraine, I worked on productivity. And to that point, I made my numbers within the first year. In regard to patients understanding our role, there was a small upswing in the patients learning our role, but I actually had my role printed on the back of my business card. So when patients would take my card, they could flip it over and say, oh, okay, this is exactly what a nurse practitioner does. So I thought that was, very helpful. But in that particular practice, it allowed for immediate, increased access in healthcare for very busy and, over-scheduled physicians. So for acute visits, routine visits, diabetic counseling, the whole gamut. And it worked out so well that the group itself expanded to more than 10 nurse practitioners, within all of their primary care sites. Interestingly and additionally, with that role, I was actually encouraged to carve out my own clinical practice. So I had my own office practice. I did some, monthly rounding at nursing homes. I was one of the primary providers at an addiction treatment center. We ran the service there for the patient population. And I incorporated home visits into my practice. So right at the onset, there was a lot to do, and it, as a nurse practitioner, developed and carved out my role there. Now, I was there for more than 12 years, and I then moved on to a large academic medical center. And I can tell you, it's outpatient, it's busy, it's a urology practice within a large academic medical practice. Urologic care is in high demand, and there's so many components that are similar to primary care as far as patient access, getting patients in to take care of many problems that aren't needed to be addressed by a specialist in regard to like a surgical need. But much of, this care that I give is urologic care, and it's provided to patients, in the whole Philadelphia and suburban area. We have many patients that come from, the Northeast Corridor and head down 476 to receive care. And I can tell you this really filled a need at the University of Pennsylvania. So in this role, I increased the patient access to care, even with all of my physician colleagues and urologists. There was still a need for more care. So, in that respect, that's where my professional journey has taken me thus far. But similar to Lorraine, and I'm sure we'll get into this, a little further into the discussion, but health policy is my passion. It's her passion. We've been involved in our, regional groups, our state group, our national group. For me, it's been the Philadelphia Area Nurse Practitioner Group, our state nurse practitioner group, the Pennsylvania Coalition of Nurse Practitioners, where, I served on the board, and then as president, similar to Lorraine, and also part of the American Association of Nurse Practitioners as a member, and also as a fellow of the American Association of Nurse Practitioners. So as far as what I'd like to complete before the end of my career, that might be beyond this, but I would say, continue to increase the awareness of the nurse practitioner role in Pennsylvania within the health system and beyond, to do more clinically, evidence-based research on my patient population, which is currently urology. And lastly, to really succeed with my nurse practitioner colleagues in, bringing Pennsylvania to where we want it to be, which would be a full practice state in Pennsylvania.
So similar to Adele, I started my professional journey in that primary care practice in Carlisle, Pennsylvania. I was with two physicians. When I joined the practice, there was one other nurse practitioner there, one of the physician's wives, of course. But she left shortly after that. She felt she was, needed to grow outside the confines of his practice. So for a little while, I was the only nurse practitioner there. By the time I left, they had hired two more nurse practitioners. So there were a total of four of us when I left there. And I left there after 6 years to open my own practice. And that's kind of the journey that I've been on since then. I've gone through various iterations of practice ownership. I've had partners. I've not had partners. At one time, I was a part owner of a very sophisticated integrated health practice. We had myself as the primary care nurse practitioner. We had another nurse practitioner who was practicing homeopathy. We had a massage therapist. We had a mental health counselor. We had someone who was practicing Chinese medicine, herbs, and acupuncture. We had another practitioner who was practicing polarity. And we were doing what I had always dreamed about doing, which was bringing all of these facets together under one roof. Unfortunately, in 2008, the economy crashed. And I was the only practitioner in the practice who was taking insurance at that time, which we should talk about that because that was a whole nother thing as an independent practitioner trying to get credentialed with insurance companies back in the early to mid 2000s. But so that practice closed and I ended up opening a small primary care practice, which I kept open until about 2016. Then my kids were in high school. They were leaving home. I decided I didn't want to have a private practice anymore. It was taking too much time away. So I worked in the emergency department for about 6 years, became certified in emergency medicine, which was just an outgrowth of my love of emergency medicine. I've been running ambulance since I was 16 years old. So it was no big shift to get into the ER. I did that for a while, and I had about a half a dozen patients who absolutely positively refused to get a new primary care provider. I was taking care of them literally out of my dining room. They would come in, I would do their visits. I wasn't charging them any money, but I had paper files in my drawers. And I finally, after a couple of years, said to my husband, I have to open another practice, because if the State Board of Medicine finds out I'm treating people out of my dining room, I'm going to get in trouble. Like, I'm going to get dinged for this. I had a collaborating physician. I wasn't breaking the rules, but it was just crazy. So I decided to reopen a practice in 2017. I have a very small direct primary care practice in Carlisle that serves primarily a population of people who are either in part-time jobs and don't have insurance for one reason or another. They might work a couple part-time jobs, or they work in a full-time position that doesn't offer them benefits, or they're self-employed. And then we work out a payment schedule for them to come in and see me, and I take care of all their primary needs. And then back in 2021, I was doing some consulting, and I ended up purchasing a relatively large primary care practice in Massachusetts, which I now manage and run. That's physically where I am today, although it's not my primary site. I'm physically in Massachusetts at that practice this morning. But we have 4 nurse practitioners here. We have a patient population of about 1,500 patients. And the big difference there is Massachusetts is a full practice authority state. So when I came here, I did not have to go through the hassle of trying to find a collaborating physician. I sent them my paperwork. They saw my credentials, the fact that I'd been working with a collaborating physician for the last almost 30 years at that point, and I was granted full practice authority. So here, myself and the 3 nurse practitioners that I employ up here, we don't have any constraints for practicing. We can do whatever is within our scope of practice here. And amazing, we haven't killed anybody yet in our practice by not having a physician to go to and see when we have something we don't understand. We do what we would do anywhere, which is we reach out to our colleagues, we do referrals, we get our patients to the appropriate practitioner if it's not something that we can handle in our practice. And that's what I'm hoping for in Pennsylvania. That's definitely one of the things that I would like to achieve by the end of my career, is to have full practice authority in Pennsylvania, so that my colleagues in Pennsylvania can practice the way that I do up here, really the way that I want to, without constraint. The other thing that my NP journey has taken me on is I'm co-founder of an organization called the National Nurse Practitioner Entrepreneur Network. We lovingly call it NNPEN. NNPEN was started by myself and 2 other nurse practitioners and a nurse attorney, because we believed that one of the reasons that nurse practitioners were not venturing out into the world to start practices was because there was no business education as part of our training. When you go to nurse practitioner school, you don't get any education in how to open a business, how to negotiate contracts, how to run a business, how to get credentialed with insurances. I mean, most of that is on-the-job training, or, like I like to say, the school of hard knocks. And trust me, I've been knocked around a good bit. So we started this organization we provide education for nurse practitioners who want to become entrepreneurs, who own their own practices and need support in one area or another. They want to add services. And we have grown since we started that practice in organization in 2017. We now have over 250 members. We're offering courses, a 12-week course on business basics, teaching people the basics they need to get started. So the other thing that I would like to achieve by the end of my career is to see an integrated network of nurse practitioner entrepreneurs who are actually able to come together, who are able to find each other, because it's really hard to find someone who owns their own business. There's no central point for registration. States don't necessarily keep track of it. AANP doesn't necessarily keep track of it. The state organizations don't keep track of it. And we'd like to become the repository for that, so that we can bring all of these nurse practitioner entrepreneurs together, so that we can learn and grow and really expand the impact that nurse practitioners have on delivering care, primary care, specialty care, whatever, education, whatever nurse practitioners are doing out there, finding the niche that's in their community and really expanding the ability of NPs to be business owners and be successful and have sustainable practices.
Do you have an NP subspecialty? And if so, Can you discuss that a little bit?
So I'll take that. So I addressed it a little bit before. So I'm primary care trained, and urology is, a subspecialty, and has many components of primary care. I see adults, which is, where my focus is. So men and women who need, urologic care, with primarily urologic problems, and then also I have a large urologic cancer surveillance practice, and many of these surveillance issues can be followed by a nurse practitioner with relative autonomy. So specifically, bladder cancer surveillance, renal cancer surveillance, and the like. So to say your question, so urology within primary care.
And my subspecialty really is entrepreneurship, as I alluded to before, and advocacy. In primary care, family practice, we see all different kinds of patients in all different areas of specialty. So, I am seeing them and screening them and directing them to where they need to be. I think, the subspecialty there is not being a subspecialist and knowing a little bit about everything, but my real passion at this point is empowering nurses, both in the legislative arena, trying to get them to understand the importance of why they should be involved in their state and national organizations, why they should be writing letters to their legislators, why they should be going to events like Lobby Day, why they should be aware of the legislation that's going to affect their practice, whether it's at a state or national level. So that, I think, is a subspecialty for me, as well as entrepreneurship, which I gave you the spiel on entrepreneurship. I really believe that nurse practitioners are going to be the entity that saves the healthcare system from its current implosion. We are the most trusted profession in the United States. We have been for over 10 years. And when you ask people, what profession is out there that can really make a difference and save healthcare from, imploding or becoming worse than it is, over 50% of those people believe that nursing has the overall experience, the knowledge, and the foresight to be able to bring healthcare back to a place where, we're not catering to insurance regulations or prior authorizations or, all of the crazy things and limits that insurance put on it that makes it difficult for practices to move forward. So I think, if I have to talk about a subspecialty, I think saving healthcare through entrepreneurship and legislative advocacy is probably where I'm at now in my career.
Well, I think that's a perfect answer, Lorraine.
Well, I've been blessed. I've been blessed in the last 30 years as an NP. I've been blessed to be able to achieve a lot of goals, owning my own practice and, being published and being able to speak at state, local, and national conferences. And, at this point in my career, I think, my obligation as a professional is to give back. And that's really what I'm trying to do now, through all of these, through NNPen and through speaking and through precepting students and what have you. So, the way that we're going to save healthcare and the way that we're going to bring NPs to the forefront is by, those of us that are experienced giving back into the profession.
Aside from restrictive practice, are there any past, present, or even future roadblock advocacy issues you'd like to address?
I'm going to take this one first, Adele, if you don't mind. As a nurse practitioner practice owner, I can tell you that one of the biggest roadblocks that we run into is insurance companies and credentialing. It's very difficult to get insurance companies to recognize independent nurse practitioners and give them an independent contract. Most of the time you have to be contracted under the practice or under the physician that you're working for. This makes us invisible when they're doing statistics and talking about what nurse practitioners are delivering or contributing to the healthcare system. If it's being billed and paid under a physician's name, the nurse practitioners are not getting the credit that they have earned for seeing those patients. I can tell you back with my first practice, Capital Blue Cross, I was credentialed with them for 3 years. Now, bear in mind, the name of my company was Bock CRNP Services. That was the name of my company. And about a year and a half to 2 years into being open and operating on my own, I got a letter from them saying, we didn't realize you were a nurse practitioner. We don't credential nurse practitioners. Just, oh, by the way, in 30 days, you're no longer going to be able to bill us for services. And about 50% of my practice was Capital Blue Cross. So it was a huge barrier to have them pull that out from underneath me and no longer be able to bill insurance for those patients. People pay a lot of money for health insurance. Employers pay a lot of money for health insurance. If people have health insurance, most of the time they want to go to a practice where they can use that. So, you know, that was a huge roadblock, and it's gotten a little bit better through a couple of organizations that I was privileged to be part of. One of them, the Multi-State Reimbursement Alliance. We were able to get some insurances to recognize nurse practitioners as primary care providers and contract with them, but that's still a daily fight. So, you know, payment models for nurse practitioners, the fact that we only get 85% of what the physician gets from most payers when we deliver the exact same kind of care. The fact that we are highly regarded by our patients. If you look at the outcomes in over 100 studies, our outcomes are the same or better, yet we are being reduced in our payment by 15%. I can tell you as a practice owner, my electric company doesn't discount my bill 15% because I'm a nurse practitioner. My employees don't agree to be paid 15% less than the other employees in other practices because I'm a nurse practitioner. So to me, those are huge roadblocks and things that we need to advocate for as we move forward, in addition to full practice authority. Because if we don't have any margin, as my friend Sandy Berkowitz, who's the nurse attorney partner, you know, she says all the time, no margin, no mission. I didn't go into this to become a millionaire. That's not what's going to happen to me. But if I can't make enough money to keep my practice open, I can't serve the populations that I'm trying to serve. So fair reimbursement and recognition by insurance is a huge issue.
So I would say that my advocacy journey, you know, started early on with the Philadelphia area nurse practitioners. And, you know, during that time, it was in 1995, we started, you know, where we continued. We hadn't started because it was going on long before I joined, but it was our journey towards prescriptive authority in Pennsylvania. So we worked on the grassroots effort to achieve this, and it was a huge win for patients. Nurse practitioners today, they don't even remember that we didn't have prescriptive authority. And there were so many issues surrounding that issue, like where, you know, would we be able to prescribe? Did we have the knowledge? Of course we had the knowledge. Were we good prescribers? Well, actually, I think a lot of studies say that we are the best prescribers of medication. So this legislative, you know, win for us really helped with patients getting the care that they need all across Pennsylvania. And I think that, you know, we keep going back to being in a reduced practice environment, which Pennsylvania is. And, you know, we're looking, you know, to be like our surrounding states, like Massachusetts, where Lorraine is, New York, New Hampshire, Rhode Island, Vermont, Connecticut, Delaware, Maryland, you know. And so why is Pennsylvania last? I'm not sure about that, but, you know, we're hoping to change that. And I think that, again, we need nurse practitioners across Pennsylvania. We need member involvement. And I think that those of us who are, you know, within these organizations, we really try every single day to move the profession forward, to engage the younger nurse practitioners, to engage our colleagues who are alongside us. We hope that everyone will be an advocate. So that's our goal, that we'll all be advocates for the profession, even if it's in a different way. So one of our past roadblocks was the prescriptive authority. Our present roadblock is reduced practice. And the insurance constraints. So we have a lot to do.
Do you have any closing thoughts you'd like to share?
Well, for me, I like to say that as a profession, we really need to achieve true provider status, and that goes along with our, profession. We're advanced practice nurses, we're nurse practitioners, and our state environment should reflect our professional practice. So true provider status, I think, is something we need to achieve. We need to achieve, more member involvement in our profession, and that's something we're working on. And then lastly, to have, to challenge our nurse practitioner colleagues to get involved with professional advocacy.
I think my parting thoughts are, this is a great profession. Right now, I think sometimes people hear all the negatives about nursing. They're overworked, they're underpaid, there's mandatory overtime. People are leaving the profession after 2 years. But Adele and I are testament to, people stay in this profession because it's a great profession. We've both been in it 30 years or more. And, I'm going to stay in it until I retire. I'm not changing professions. There is a lot of opportunity, not only as nurse practitioners, but also, in just being a bedside nurse and making a difference in people's lives, in, moving into one of the other advanced practice nursing roles, such as nurse anesthetist or certified nurse midwife or clinical nurse specialist. And I think, people have to understand we bring the same education to the table as far as, having a science background, having a mathematics background. There's a huge movement right now on the national level to have nursing recognized as a STEM education. The fact that it's not is, I think, primarily, unfortunately, because we were primarily a female-dominated profession. We have the same sciences, we have the same math, we have the same need to understand technology as all of the other professions that are listed in STEM. So I think it's really important for nurses to get to the table. We need to be on boards everywhere. We need to start getting on hospital boards. Nurses are the #1 employed profession in any hospital or health system. And yet, if you look at boards everywhere, there's rarely a nurse on one of those boards. There's not nurses at the national level on too many boards. We're starting to break through that glass ceiling, if you will. But, I want to motivate people. I want nurses to understand you don't have to be satisfied to stand and take it. You have the power. When we band together, in Pennsylvania alone, we have the largest profession in Pennsylvania that's licensed of any other board, any other licensed profession in the Commonwealth. Nurses are #1. We can make a difference. We can move the needle, and we can get what we need for our patients and take care of them in the way that they need to be taken care of, give them access, and set out to do what we really were trained to do and what it is that we want to do and take care of patients the way we want to. We just have to get together and exert the inherent power that we have, just simply in numbers, not, take away education. Just in numbers, we have power. When you add in how well educated nurses are, we are a powerhouse, and we need to step forward and start, getting people to deal with us rather than just saying, oh, they're just the nurses. Oh, they're just the nurses. That sentiment needs to go away.
Thanks again to you both for your time today.
Thanks for having us. This was great.
Yeah, thank you very much. My pleasure. Thanks, Lorraine.
Thank you, Adele.